Well, welcome back. This week we're going to transition out of kind of more abstract matters of trying to figure out what it is essentially that makes an action right or wrong. Last week we looked at some different kinds of ethical theories, consequentialism, deontology, virtue, natural law, casuistry. Those sorts of things. And it's not as though we're forgetting that. That those theories are still going to make up the conceptual network by which we think about ethical problems. But of course, this week we're going to begin to focus much more on bioethics and then ultimately nursing ethics next week. So let's get started. There are 4 standard principles of healthcare ethics. I say healthcare ethics because bioethics is very broad. Healthcare ethics is ethics as it relates specifically to the delivery of healthcare and the obligations of healthcare professionals. These 4 principles that you see before you, yes, are standard. They arose out of the Principles of Biomedical Ethics, which is a book that's in its umpteenth edition now from Thomas L. Beecham and James Childress. And you notice in our book, Janie Butts and Karen Rich reference Beecham and Childress a number of times. I would say that virtually every hospital ethics committee is in some ways conversant with these principles, or strives to be at any rate. There is maybe a little bit of controversy surrounding them because some bioethicists, some healthcare ethicists, clinical ethicists, disagree that the best way to think about making decisions about what to do is not by applying principles, but by, perhaps, analyze or comparing cases like casuistry that we talked about last week. But I think all of that is much ado about nothing. A principle, from my point of view, is simply some standard to which we appeal to figure out what to do, a guidepost. And I don't think we need to worry about any sort of these meta-ethical controversies that go on in the bioethics world. So let's take a look at these 4 widely known principles of healthcare ethics, and then take a closer look at each. There is the principle of respect for autonomy, something that you're probably already familiar with. It simply refers to a healthcare professional's obligation to promote the patient's capacity to take control over his or her treatment, typically by giving the patient adequate information so that they can make good choices for themselves. It also, of course, captures trying to remove any sort of barriers that might interfere with what the patient wants to do. More on that later. There's also the principle of non-maleficence. The principle of non-maleficence is just simply the obligation to refrain from harming, kind of to do no harm, as it were. There is, thirdly, the principle of beneficence, and that is the obligation to promote good. Most often the good of the patient, sometimes from a public health point of view, the good of the community, the good of the country, and so forth. And then finally there's the principle of justice. The principle of justice, unlike the previous 3 that were more or less principles of clinical ethics, the principle of justice in many ways deals with a broader a broader spectrum of questions, many related to how we ought to allocate resources in society. So the principle of justice says that healthcare professionals and healthcare institutions have an obligation to allocate resources in a just manner. Now that could be something as how to best allocate our use of ICU beds when not every patient who might need one can get one. How do we prioritize, as it were? Or it can be more along the lines of macro allocation. Who in society is entitled to health care and why? How do we allocate society's resources in a fair and equitable manner? That's the principle of justice. Well, let's turn to a closer look at the principle of respect for autonomy, really starting out by thinking about some of the very conditions for the possibility of autonomy, or maybe different senses of autonomy. I mean, autonomy, generally speaking, just literally means to be self-governing. Autonomous is what autonomy is. You are self-governing, and we think that that's important. It's to be in control over your life, to have self-determination. By the way, self-determination is another term that's often used, I guess, more or less synonymously with autonomy. In fact, I think the American Nurses Association Code of Ethics uses the term self-determination more than autonomy, but it's the same thing. We say of persons, one of the core important components of being a person is to be able to govern your life according to your own values, your own choices, the things that matter to you, and we think it's important to honor the differences among people. But I think what's important to me as a patient might not be important to you as a patient. It's healthcare professionals have an obligation to determine what patients care about and to try to offer treatments that are consonant with the values and the choices of patients. That's what autonomy is really about. But let's think of some of the very conditions for autonomy. What makes autonomy possible? Well, one of the most historically important ones was the capacity for rational choice. In fact, we saw that last week in our discussion about Immanuel Kant. Remember, that was Kant's deontology. Don't forget the formula of universal law and the formula of the end in itself. Remember, in particular, the formula of the end in itself. According to Kant's deontology, we have an obligation to treat persons as ends in themselves, namely to refrain from using them, and maybe phrased more positively, to interact with them so that they can control their own lives through their own choices. To treat a person as though they were simply a thing is to treat them as something less than rational. Rational beings are the sorts of beings that govern their lives through their own choices. Non-rational entities like rocks and squirrels are simply at the mercy of external forces, even if those external forces are psychological instinct or something like that. So capacity for reason is one of the core foundations of autonomy. Think for yourself, how is it that we really respect the patient's autonomy? If we want to deliver care that is consistent with their concerns and their choices, we empower them with information. We remove any observable obstacles to rational choice. So capacity for rational choice is one important condition of autonomy. Another one doesn't concern so much, our ability to think about our circumstances and what to do, but rather being free from anyone or anything that interferes from what we want to do. and that is freedom from coercion. You can imagine a situation in which a patient is fully informed, they have no cognitive deficits whatsoever, so the capacity for rational choice is right there, you know, working quite well. But let's say they have a family member that might kind of bully the patient out of doing what she wants to do, or even a clinician that might be coercive, that is interfering deliberately or maybe not deliberately, you know, or accidentally interfering with what the patient wants to do. As we'll notice a little bit later on, you know, coercion, you know, preventing a patient from doing what he or she wants to do isn't always the most obvious thing to identify. Sometimes that's obvious. I mean, geez, if we physically restrain someone, usually we physically restrain them because they lack the first condition of autonomy, capacity for rational choice. But you know, or if you know, if a clinician or if a family member deliberately, you know, threatens, you know, the patient and the clinician, you know, that you could imagine, you know, an oppressive husband, perhaps from a different culture, that is very dismissive of his wife's treatment choices and wants to take over the you know, making decisions for her care. Sure, I mean, in fact, you may have even seen things like that. But oftentimes, coercion comes in much more subtler forms. Maybe sometimes a patient just doesn't want a family member to know about a choice. So, you know, when the family member is present, the patient will seem to be expressing one choice, but when the family member is not present, the patient might seem to be expressing another choice. So the obvious instances of coercion are much less troublesome than the subtle, insidious forms of coercion, whether it's just a knowing look, or maybe a physician uses, you know, intimidating language to talk about a treatment that he or she does not want to perform, and uses very emotionally appealing language to talk about a treatment that he would think is the best one. You know, those are subtle forms of coercion. Now let's take a look now at probably the most evident and obvious application of autonomy and respect for autonomy in clinical healthcare ethics, and that is informed consent. We're all very familiar with informed consent. You know, I guess unfortunately, informed consent has come to healthcare, you know, through legalistic channels. So oftentimes we think of informed consent as kind of a legalistic hoop to jump through. But that's not the moral rationale behind it at all. We care primarily about informed consent because it's the way in which we can empower patient autonomy, the way in which we respect and honor the patient's autonomy, their capacity and their desire to control their treatment according to their own values and choices. That, you know, like we learned from Kant, that goes right to the heart of what it is to be a person, at least from one sort of tradition of philosophy. So informed consent is vitally important in the way we honor the dignity of patients. So let's take a look at the various conditions of informed consent, and then I would like to take a closer look at a cluster of them. Janie Butts and Karen Rich, again, cite Beecham and Childress principles of biomedical ethics when they go through these 7 conditions of informed consent. They are competence, voluntariness, disclosure of information, recommendation, understanding, decision, and authorization. Competence means that a patient has to have the capacity to make the treatment decision. Voluntariness, they have to be free from coercion. They have to make the decision voluntarily of their own free will. There must be adequate information disclosed to them to make that decision. The clinician should make a recommendation based on her or his assessment of what would be best for the patient and why. It's understanding. The patient has to understand the information that's disclosed to him or her and also understand the rationale behind the clinician's recommendation. Then finally, the patient has to make a decision in favor of a particular plan and then oftentimes formally authorize that plan. I want to start with what I think is probably the most complicated of the conditions, and it is the first one, competence. What does it mean to be competent? Well, I mean, we know that there are a range of tests, maybe formalized tests that can be given to a patient in order to assess competence. Oftentimes, you probably thought yourself that you're not convinced that this particular patient is competent to make these decisions. We're concerned about competence because we don't want a patient's lack of autonomy to come back to bring harm to that patient. So when we're talking about competence, clearly we're referring to that condition of autonomy that refers to capacity for rational choice. Being able to understand things is part of being competent. So, when we talk about the competence of a patient, we're really talking about a range of different skills, from understanding information, from being able to remember information, being able to compare outcomes, to being able to understand probability judgments. If there's a 10% chance of post-operative bleeding or something like that, that requires being able to understand a probability judgment. So when we talk about competence, it really is kind of a diverse mixed bag of different sorts of cognitive skills. And I should also add affective emotional skills. And sometimes a particular patient might be said to be incompetent, not because they have any sort of cognitive deficit, but maybe they are clinically depressed. They simply don't care in an appropriate manner that would be reflective of a healthy person. Now, philosophically, what would count as having enough decision-making capacity to be considered competent? And that's really what we mean when we talk about competence. A patient is said to be competent if they have adequate decision-making capacity. Oftentimes, you'll see the word competence and decision-making capacity used interchangeably. I don't think that's the worst thing, but I think the best way to understand is to say a person is competent, a patient is competent if he or she has enough decision-making capacity in order to make the particular decision in question. So what it comes down to then is that there is no definite threshold level that would make someone competent in general. In fact, there's no such thing as being generally competent. If I asked you whether you were competent, hopefully you would respond by saying, competent to do what? I mean, you're competent to do a whole range of tasks related to your profession, assess a patient history, perform a range of procedures, But if I asked you if you were competent to, switch out the electrical box in your basement, you'd say no. So competence is task specific. We are competent to do some things, but not competent to do others. In connection with patient competence, what we really mean is does the patient have enough decision-making capacity to make the particular decision at hand? So that means that all judgments of competence are done on a sliding scale. What I mean by that is this. The more complicated a treatment decision is, the higher the decision-making capacity needed to count as competent. So if a patient has to make an extremely complicated decision, well, in order for that patient to be competent to make that decision, they have to have a relatively high level of decision-making capacity. In other words, they have to be really with it. On the other hand, some healthcare treatment decisions are not very complicated at all. They're pretty simple. And when that's the case, perhaps a low level of decision-making capacity is all that's needed in order to make that decision. You could imagine an adolescent or a child, I know legal competence is 18, but that's just, in some ways, an arbitrary decision in the eyes of the law. But you could imagine a child being perfectly well competent to make a very uncomplicated treatment decision. So that's important to keep in mind. Oftentimes we think of competence in these broad sweeping, absolutist senses, and it's not the way it is at all. If someone, God forbid, fails a psych consult and they're declared by the court to be incompetent, well, that's a very difficult thing to undo. I mean, the reality is that that particular patient was probably competent to make a whole range of treatments, but now that that patient is considered incompetent in general, they're not allowed to make any decisions. And that does not really do justice to the way a healthcare ethicist, a clinical ethicist thinks about competence. The ethicist knows that a judgment of competence is always relative to the decision at hand. If the decision is quite complicated, the patient might need to the patient might need a fairly high level of capacity to be considered competent. But that's not always the case. Moreover, sometimes a patient's decision-making capacity could fluctuate during the course of a day. Think of a long-term care situation, skilled nursing facility. An elderly patient might be very lucid and clear-thinking early in the day, and might be perfectly competent to make certain sorts of judgments about their care, while later on in the afternoon, in the evening, they might be more confused and less capable. So it's not a one-size-fits-all. Now, I want to complicate this just a little bit. But it's important, and I promise we'll understand it. We judge competence, like I said, on a sliding scale, but look at that fourth bullet point there. We also judge evidence of competence on a sliding scale. Now, what does that mean? It simply means this. I mean, ask yourself, well, how much evidence do you need to have that a patient is competent? Well, I don't know. It actually depends. It depends on how much risk is associated with the decision. What's at stake in a decision? If there's a lot at stake, we want a lot of evidence that this patient knows what they're doing. If there's not a lot that hangs in the balance, we don't need a big amount of evidence that the patient is competent. Maybe just our general impression of the patient might suffice. For instance, if I'm an otherwise healthy person, but I'm refusing, let's say I have a severe coronary blockage, and they say, well, you really do need this procedure, let's say an angioplasty, and I say no, and there's just, you can't imagine why someone would refuse a procedure that's very much needed for them. In those cases where a patient's decision really significantly puts them in harm's way, it's not that they're incompetent. They might be perfectly well competent. It's just that our obligation, given the risk that they're taking on, is to make really sure that they know what they're doing. So we need a lot of evidence. So for very risky decisions, if there's a lot of risk associated with a particular decision, we need a commensurately greater level of evidence that that patient is competent. By contrast, if there's not a lot at stake and not a lot of risk, we may not need very much evidence at all. If I were, let's say I don't know, had a few stitches put in the emergency department, and there's, everything looks fine. In fact, it was borderline call whether I even needed anything. They just, they would just put some glue or something in there. You know how it goes. And as I'm walking out, they say, hey, take this antibiotic ointment. You might just dab a little bit on there tonight. Otherwise, it could get a little itchy and red. If I said no, I think I'm good. I might have some at home. That refusal wouldn't be followed by a big flurry of concern, like, oh no, we got to make sure he's competent to refuse that treatment. Well, no. I mean, there's not a lot of risk. I'm not really putting myself in any way of any serious harm. So you don't need as much evidence as you would need if there was a lot of risk at stake in my decision. So, to sum up here, there are two kinds of decisions we make when talking about patient competence. One is, does the patient have adequate decision-making capacity to count as competent? So judgments of competence are judged on a sliding scale relative to the complexity of the decision. The second question has to do with how much evidence we need that the patient is competent. And that is relative to the amount of risk. We judge that on a sliding scale approach depending on the level of risk associated. So always ask yourself, does the patient have enough decision-making capacity? If they are, they're competent. That's all there is to it. But the follow-up question is, well, how much evidence do we really need to determine that fact? If a lot hangs in the balance, you want to have more evidence than you would if not a lot hangs in the balance. It's important not to conflate these two. Sometimes you'll hear someone say something like, well, boy, they're making a pretty big decision here, so I don't know if they have enough decision-making capacity. We'll have to get a surrogate decision-maker or appoint a guardian or something like that. But see, notice that sort of statement confuses these two considerations. Just because a treatment is risky, if it could involve a lot of harm, that doesn't mean that the patient needs a higher level of decision-making capacity. No. It means that we need a higher level of evidence that the patient is competent. I think if we screw that up, we run the risk of not respecting a patient's autonomy, of violating the principle of respect for autonomy. Okay, another important condition of informed consent was voluntariness. I think I've said, most of what we need to know about voluntariness. It's just, being free to do what you want to do. If you don't have anyone interfering with the patient, if the patient wants to make a choice, they should be free from coercion. They should be able to make it voluntarily, and that's what voluntariness is. In order to satisfy the conditions of informed consent, it has to be the case that the patient's making a treatment decision voluntarily, without being coerced in any way. Disclosure of information. Remember, in order for a patient to make a rational choice for themselves, remember, capacity for rational choice, one of the conditions of autonomy, in order for a patient to make a rational choice for themselves, they need to be able to reflect on the relevant information. And what is that? How do you satisfy the disclosure of information condition of informed consent? Well, I don't think there's any surprises here. Patients should know the risks of a procedure in question and the benefits of that procedure, and maybe the risks and benefits of doing nothing at all. So I think in general we can say that a patient should know the risks and hope for benefits of the procedure under question, the risks and hope for benefits of other alternative treatments, and including the risk of refusing treatment altogether. So I think that's what we think of when we think of the sort of stuff we should disclose to patients. There have been a number of standards offered over the years, meaning a number of criteria offered in order to help us determine whether or not we're disclosing the right amount and type of information. I think the one that we can dismiss and reject right away is the professional standard. The professional standard says, well, you should disclose the right amount and type of information that that other clinicians in this circumstance would disclose to patients of this sort. But of course, that's not adequate, because what if your colleagues, what if other similarly situated professionals aren't disclosing the right amount and type of information? And you could imagine a time earlier on in healthcare where physicians, for example, disclosed very little information. So if the professional standard was the only standard we had, we would be still in a very sort of paternalistic era of healthcare. A much more patient-centered standard is the reasonable person standard. The reasonable person standard says that a healthcare professional has an obligation to disclose the amount and type of information that the reasonable person would want to know in order to make a good decision for themselves. So, according to the reasonable person standard, you disclose the amount and type of information that you think, what would a reasonable person want to know? Based upon your experience with different patients, you think to yourself, by and large, I think the average reasonable patient kind of is interested in these things. Notice, you might say, well, geez, why don't you just simply disclose all of the information? But in a sense, that would be impossible. I mean, are we going to turn to the, journals of the internal medicine back to 1940 to are we going to speculate on every possible outcome, every possible risk? That would be impractical, really impossible. Moreover, if the whole point of this is to empower patient autonomy and empower their decision-making capacity, I think just snowing them over with a paralyzing amount of information only runs counter to our goal of giving them back greater control over their treatment choices. So the reasonable person standard says, well, you've got to use some discretionary judgment about what to leave in and what to leave out, that's just the way it has to happen. Now, but of course, you might be thinking to yourself, well, geez, I mean, every patient is a little different. What one person might be very much worried about, the other person might not be very concerned about. Well, that is absolutely true. One problem with the reasonable person standard is that, in point of fact, you never have the reasonable person in front of you asking questions. Your patient is never the reasonable person. The reasonable person is a hypothetical construct, that we use in health law and other areas of law, when we need some way to have a rough and ready, range of reasonability. But the reasonable person is no one in particular. I mean, the only kinds of patients that you're ever going to encounter are actual patients they have their own particular life stories, their own particular worries, their own particular circumstances, their own particular questions, and the reasonable person doesn't get at that. So that's where the subjective standard is supposed to kind of offset the deficits or the downsides of a reasonable person standard. The subjective standard says that the healthcare professional has an obligation to disclose, the amount and type of information that the particular patient before them wants to know, to disclose the information that is particularly relevant to the context of this patient, to the concerns of this patient, to the values of this patient, and so forth. I mean, if I had to have a knee surgery or something like that, I think the kind of the level of detail about the various sorts of nuances in the rehab time and resulting range of motion, given one way to do an ACL reconstruction versus another, the conversation with me would be very different than with an Olympic gymnast, right? Because basically, what's my job? I'm sitting and talking to a computer, and that's about the extent of my movement. Tonight I'll be in class and I'll be standing next to a podium, right? So that's so my life context is very different. With the sorts of things that I would want to know in order to make a decision are different from the sorts of things that someone else would want to know. Now, I think ideally the best way to think of it, the disclosure of information, is probably some combination of a reasonable person standard and a subjective standard. Of course, disclose what you think almost any patient would want to know, but then find a way to get to what the particular patient might be especially interested in. And you can do that in simple ways. I mean, it's hard because you don't necessarily know a lot about the patient, but you can go over what you think generally the average or reasonable patient would want to know, and then ask something like, well, do you have any particular concerns or questions? And at that point, pay attention to the sorts of questions that the patient is asking, and that will kind of allow you to get to the things that they're particularly concerned about, and they can kind of take responsibility in some ways for those sorts of things. So that is the disclosure of information condition. Now let's take my goal here is not to go through all of the conditions of informed consent. Disclosure of information and competence certainly are two very important ones. Of course, understanding, the whole purpose of disclosing information is so that the patient understands. There's no point to disclosure of information if you're just going to repeat a bunch of jargon while the patient's eyes glaze over. The whole point is that the patient understands, and we have an obligation to make sure that the patient understands. Asking the patient to perhaps to explain back what you've said, and and other sorts of things. And also remember, not all patients process information in the same way. Some people are very auditory learners. Some people need to sit down and look at some written material. One sort of special topic that comes up in the context of all of this is the question of intentional non-disclosure. Is it ever permissible simply to not disclose a piece of information? Well, it's a highly controversial thing. In the course of maybe a clinical study where the study is very open to prospective subjects, that there's going to be a control group, and I think subjects enter those studies knowing that whether they are taking the medication that they're wondering about versus perhaps the alternative that is out there that's being used. That's part of doing these double-blind studies. But by and large, intentional non-disclosure in clinical healthcare ethics is often looked down upon. Now, you hear the term therapeutic privilege. That means you're deliberately withholding a piece of information because you think disclosing that information would only be detrimental to the patient. Either psychologically, emotionally. You might think, oh, it's just going to, if this patient knows, it's going to break their spirit. Or maybe in a less in a less dramatic way. Sometimes we'll hold a piece of information because we don't want the patient to worry needlessly. Maybe you get some sort of a so worrisome lab result, but you want to double check on that before you talk to the patient, because it could be a lab error or something like that. But by and large, therapeutic privilege is really looked on skeptically. I think that the general sort of consensus among ethicists is that, being a healthcare professional means having difficult conversations with patients and families, and that means being able to present information in a way that is potentially upsetting, but doing it in a way that respects the right of the patient to know, and also frames the information in the most helpful way possible. And if you're not up for that, then this is probably not a good profession for you. Placebos have been, an interesting topic over the years. I think they made their way back onto the radar of ethicists a few years back. By and large, in clinical trials and in research, I think the placebo still has a place. I think it's very much kind of looked down upon in normal clinical circumstances. Sure, there could be some extreme circumstance in which, we can't control this patient. For example, we can't control this patient's pain anymore, and we've got nothing left. Why not try the power of suggestion with the placebo? But by and large, it's seen as a deception. And if we're committed to respecting the autonomy of patients, then we're committed to giving these patients all the relevant information that they would need to make rational choices for themselves. Again, I think this really just goes back to Kantian ontology. All of this just goes back to treating a person as treating a patient as a person rather than as a thing. Allowing them to exercise control over their circumstances as much as they can. Just a quick, the Patient Self-Determination Act came up in our chapter. This was, I think, 1990 or 1991. It was passed. Really, it just really emphasized, put legal teeth to giving patients adequate information to make treatment decisions for themselves, and in particular, it is the legal foundation for the reason why we have to at least inquire or ask a patient if they would want, if they have an advance directive, or if they want some assistance doing some advanced care planning. All hospitals are required to do that. All right. Another of the the four main principles of healthcare ethics is the principle of non-maleficence. That is, that's the do no harm. You have an obligation to refrain from harming patients. Sometimes we're not sure really what to do, although we know, maybe we think that the best thing to do is just to, at the very least, refrain from harming a patient if it's not clear how we might benefit a patient. Non-maleficence has some particular kinds of applications. One very common application has to do with withholding, withdrawing burdensome treatments. I know this is a highly contentious issue, and we're going to talk about it later on in the course when we talk about end-of-life care, ventilator support, feeding tubes, so forth. But by and large, when we recommend withholding or withdrawing treatment from a particular patient, a particular kind of treatment, that it could very well be that there are other treatments that we think are going to work better. It's just that the one in question is just not it's not providing benefit, and oftentimes it's only burdensome and to no good end. So why continue something that is burdensome to the patient that's not helping the patient? Sometimes it's framed in the context of futile treatment, and we'll talk more about futile treatment again when we talk about end-of-life care and those sorts of things, because that's kind of a hot topic, and we should think a little bit more about that. A treatment is said to be futile if it doesn't offer any sort of reasonable hope of benefit. Often the controversial thing about judgments of medical futility is that it would seem to allow clinicians to withhold treatments that families and patients are demanding. And many times I think healthcare professionals are justified in withholding treatments that they know are not going to offer any benefit to the patient, even if the patient or family is demanding that treatment. But again, I don't want to get into that hornet's nest of controversy yet, but it is another sort of kind of general application of the principle of non-maleficence. So that is, what's at stake in general is our obligation to withhold any treatments that we don't think that are going to be hurtful or non-beneficial to patients. So we want to do no harm. Let me just let me just layer in a couple of helpful related tips, and then we'll move on. This is specifically linked to withholding, withdrawing treatment, and also with regard to other what we call life, kind of sustenance technologies, ventilators, for example, or feeding tubes, for instance. All other things being equal, there is no morally relevant distinction between withholding treatment and withdrawing treatment. And I want us to think about those circumstances in which a treatment has been initiated, let's say ventilator support or feeding tubes, for example, but it becomes clear that the treatment does not seem to be helping the patient in any sort of appreciable way. It's not in any sort of holistic way. It's not improving the patients in any particular way, other than perhaps just extending their biological existence. Oftentimes, clinicians feel that withdrawing treatments once they've been initiated, especially life-prolonging treatments like ventilator support, that somehow it's morally worse because then you are the direct cause of that patient's death, for example. It is now widely accepted in clinical healthcare ethics that there's no morally relevant distinction between withholding treatment and withdrawing treatment. One is not morally worse than the other. That is, if we think that the patient would not have been a good candidate for a particular sort of treatment, then we are justified in withholding that treatment, and we would be similarly justified in withdrawing that treatment if it had already been initiated. So let me say that again. So if a treatment is not medically appropriate for a particular patient, it's not going to help them, we're justified in withholding it. If that treatment has already been initiated, but it becomes clear that treatment is no longer offering a reasonable hope of benefit to that patient, then we should feel justified in withdrawing that treatment. Withdrawing treatment is simply a decision to discontinue that treatment, to not continue a treatment that is no longer benefiting the patient. If the patient is such that you would not have chosen to initiate that treatment, then that's a good indication to you that that treatment should be withdrawn. I think, and that's a very important point, because if clinicians believe that they're going to be stuck, as it were, in morally not allowed to withdraw treatment that they don't think makes any medical sense, they're going to be reluctant to initiate that treatment. And I think that is a bad precedent, because we oftentimes want to try a treatment to see if it works. It may in fact offer a great deal of benefit to a patient, but we just don't know. However, if we feel that we're going to be stuck offering this treatment and not be morally allowed to withdraw it if it doesn't work, we're going to be reluctant to initiate that treatment. So that's why this point about no morally relevant distinction between withholding and withdrawing treatment is so important. If we get that wrong, we're going to be reluctant to initiate treatments that may very well benefit the patient. Let me just touch on one other thing, and then we can move on. I say, by and large, the criteria to continue or discontinue feeding tubes, medically assisted nutrition and hydration, are generally considered the same as any I should say, any other medical decision. Namely, we wonder if the treatment offers benefit to the patient and or if it's in accordance with the patient's wishes and values. Sometimes we think that nutrition and hydration, especially medically assisted nutrition and hydration, is in a separate moral category than other sorts of life-sustaining interventions like ventilator support. In reality, we ask ourselves the same questions. Is it helping or is it hurting? As you probably well know, there are a certain class of patients for whom providing nutrition and hydration may only make their life circumstances worse. Someone in the end stages of a terminal illness, their end-of-life experience may be considerably worse if we go forward, if we continue, feeding tubes on that patient, perhaps at the demand of the family. I mean, they may experience a lot more discomfort, edema, their organs may be very taxed with fluid retention and and the fluid is probably a consequence of their body shutting down, and we're doing them no great favor, insisting that somehow feeding tubes are not seen as being governed by the same sort of moral principles as other sorts of interventions. That's not the case at all. In fact, they are. The questions with feeding tubes would be the same questions with any sort of treatment. Is this, consonant with the wishes and values of the patient? And most importantly, is this offering any benefit? Is this helping the person? If not, then they can be permissibly withdrawn. What about the principle of beneficence? It's kind of the flip side of non-maleficence. It's the duty to promote the good of the patient. I think one important thing to keep in mind is that while we often think of the medical good of the patient, or we equate good of the patient with the medical good of the patient, there are other important dimensions to patient good. And I don't think this is any surprise to you as being, very seasoned healthcare professionals. Patients are persons, and to borrow the title of a very famous bioethics book, The Patient as Person, the patient before you is not just a repository for some disease process, but that they're a person with issues. So the senses of patient good really track those dimensions, the psychosocial dimension, the spiritual dimension, and the overall, the holistic patient, the holistic good of the patient. If you think about it, what is it that makes a disease process or a condition a bad thing for a patient? In many ways, because it takes them out of their life and interferes with the other sorts of valuable experiences that they would otherwise pursue. Whether it's gardening with your arthritis, why is that bad? And the arthritis in your knees, for example. Well, maybe it's because you can't garden you're not as social as you used to be. You can't be with your friends because you just don't move around as well. Or so when we're thinking of the good of the patient and promoting the good of the patient, we can't focus so exclusively on the medical good of the patient and lose sight of, in many ways, why the medical good of the patient cares to begin with, or matters to begin with. In the context of discussions of beneficence, the term paternalism often surfaces. Paternalism really refers to disregarding or overriding the choices of a patient for that patient's own good. I mean, imagine, we need only think about the Dax Cowart circumstance, the video that we watched this week. I mean, so many of the concepts that we've talked about so far are so, prominently reflected in that video. But, I think the question we're wondering is, was it morally permissible for medical professionals to disregard the treatment refusal of Dax Cowart? I think probably watching that video you thought no. Let's distinguish between soft paternalism and hard paternalism. Soft paternalism is the activity of overriding or disregarding the wishes of a patient for the patient's own good when that patient does not have decision-making capacity, when they're not competent. So when we think that the patient is not competent to refuse treatment or to make a treatment decision, we often override their, especially if it's an emergent situation, we override their decision and we do what we think is best for them despite their wishes. Self-paternalism, if you think about it in that sense, is not technically at odds with respect for autonomy, because we only appeal to soft paternalism when we say that the patient, in a certain sense, lacks autonomy. If they don't have decision-making capacity, then they're really not in control of their life. They don't have, they're not rational, right? By contrast, hard paternalism refers to overriding or disregarding the wishes of a patient when that patient is perfectly competent and informed to make decisions. And I think we would all agree that, for uncontroversial reasons, this just hard paternalism just, is really simply a straightforward violation of the principle of respect for autonomy, a straightforward violation of autonomy, and immoral on uncontroversial grounds. So, if the patient does not have adequate decision-making capacity, and a treatment decision, for example, has to be made quickly for them, we often just simply make a decision on their behalf, sometimes disregarding their incompetent wishes. All right, and we're going to be kind of circling back to a lot of this stuff. I just want to make a few brief comments on that last principle in the chapter, the principle of justice, and that'll wrap it up for chapter 2. I think that's the most important stuff. The principle of justice, as I said, has to do with, is most often associated with allocation of resources, whether it's ICU beds or even human resources. I mean, how many nurses should staff a floor, given that we maybe have a relative scarcity of them. How do we allocate our dialysis machines, especially let's say in a rural area where we don't have a lot of technological resources to draw from. In a very, in terms of macro allocation at a broad, large scale, how should society allocate its resources? We'll talk a little bit more about that later on, so we don't need to go into particular questions of social justice, different theories of social justice right now. But I think it's enough that we know that justice in this context typically refers to the systematic rationale by which we make allocation decisions. So, well, okay. As always, I thank you for your patience and your attention, and I will see you online, and offer another lecture next week.